uh, have Mark with us. My intention is to introduce him. I'm Linda Liskowski-Jones. I'm a advanced practice nurse. I'm a patroller at Blue Mountain Ski Area in Pennsylvania, and I am part of the Bear Creek EMS program as well. And I was so happy to be able to recruit Mark into give this presentation to us tonight. So a little bit about Mark. I'm going to do a formal introduction for Mark. Mark is an emergency department nurse. He's a paramedic instructor coordinator at Denver Health in Colorado, and he's a ski patroller at Copper Mountain Ski Resort. He collaborated with the Department of Defense, Military Training Network for nursing training. Prior to deployment, he set a standard for emergency nursing that remains a component of military training and readiness. He's a retired major in the Army. He's served in various leadership positions. He's had 26 peer-reviewed publications. He's a frequent speaker at local, national, and international conferences. His clinical experience includes emergency care, emergency medical services, critical care, ground and flight transport nursing. He retired from the U.S. Army Nurse Corps as a major in 2014 after 29 years, having worked at the Pentagon, Walter Reed Army Medical Center, Combat Surgical Hospital, and a medevac dust-off unit. Clinically, he has worked in settings that range from a community hospital to large metropolitan level 1 trauma center, both as a registered nurse and a paramedic instructor coordinator. So, Mark, thank you again for being with us, and I'll turn it over to you.
Thank you so much, Linda, as well as Eric. I appreciate the opportunity to be here today. Let me get my slides set up for you so everybody can see. All right, give me a sec. Let me get So let me start off by saying thank you very much. Could everybody see my screen? Yes? Excellent. So a couple months back, I think we were having conversations with Linda and myself and some others, and had been invited to provide a presentation for Bear Creek, and I said sure, absolutely. So I was just really excited to have the opportunity to present to you. And so again, thank you for that great introduction, Linda and Eric. We're going to talk about the pediatric patient, and don't be afraid. And so yes, I am a Copper Mountain ski patroller. And I also work at Denver Health in the emergency department. So a little bit about me. You're like, who is this kid? And who's talking to me right now? Well, I started out at 17. I graduated high school really, and I enlisted into the military. And had a great career. My first job was a flight paramedic. So my recruiter said, why walk when you can drive? Why drive when you could fly? So I went right to flights. I landed on, a pretty lucky star. And so I did that for many, many years and just had a great military career. And combined with that, I went from green to gold. I had the ability to get a direct commission as a registered nurse because, hey, you could do maybe a little bit more as an officer. And so I had many great years as a non-commissioned officer as well as an officer. And actually, my ski patrol career started later on in life. Many, many years ago, a colleague said, "Hey, Mark, why don't you join ski patrol?" Was the EMS coordinator for, the Detroit metropolitan area and raising a family. I just didn't have time. I worked all the time, and I just didn't have time. And so a couple years later, when my kids were older, they said, "Hey, we want to join ski team," and finding out how much snow sports actually cost. It's a lot of money. So I went to my buddy after many years and I'm like, "Hey, what do I need to do for ski patrol?" And he's like, well, you take these classes and this and that. And so I actually shut my mouth. I sat in the back of the classroom. I did what I was told, and I became a ski patroller in 2010. Well, after that first year, um, people found out what I did for a living, and they're like, "Oh, buddy, you're going to be an instructor. You're going to do this. You're going to be doing that." And I'm like, "Whoa, whoa, whoa!" And so I'm like, "Okay." And so, that was just the beginning. I moved out here permanently um, a remove back in 2015 and hired on with Copper, and it's just been a great patrol. It's a tiered patrol. In other words, everybody's a patroller, but some people are blasters and they have their ATF license. Some people are advanced life support. So they're either docs, nurses, or paramedics, and that's the category I fall in. Some people do avalanche mitigation. So just been really lucky. And throughout the year, I work at the Level 1 Trauma Center in Denver, Denver Health. And if anybody's ever heard it called the Knife and Gun Club, well, that's pretty much the Knife and Gun Club. But we're looking at, I'm going on 40 years of doing emergency care either from the street or in the air, in the city or in a foreign country. And I love what we do because we get to provide care. So this is the team I'm on. A little shameless plug, and for those that we love our ski patrol. I just looked at this month's Ski Patrol magazine, and I said a lot of people owe us beer. We have an unwritten rule in the pro division. Anytime your picture is in publication, you owe people beer. And so there's lots of beer going around right now just because of the promotion that the team has invested in, and it's just been a great opportunity for everybody here. And so these are the guys and gals that I work with, and they're just again utmost professionals that care for patients in on the mountain. So just to let everybody know, I don't have any final disclosures and no conflict of interest. And so the question I have for everybody is, how many of us have cared for a critically ill or injured child before? I mean, you could kind of raise your hands in the chat and see what that looks like. But I think a considerable amount of us have taken care of um, sick and injured children before, which is a considerable amount, right? Let me just click out of this one. For some reason, I've And so just to let everybody though know, there's going to be no graphic pictures in this talk, but this content can be triggering for some. And so um, I want to, for mind, body, and spirit, just to know that this is an educational opportunity for everybody, but not to be triggered. And again, with any presentation that we have for credit or not credit, we really should have some objectives, right? And so some of our basic objectives here, we're going to talk about the unique A&P of children leading to specific injury patterns. And I think having a foundation of anatomy and physiology is really important. We're going to talk about an initial assessment of the injured child or ill child for that matter. Um, We'll talk about integrating trauma resuscitation in our alphabet or ABCDEs, which is always going to be important because, a lot of patients that we see on the hill, at least 60% of them or more, will be some kind of injured guest. We'll talk about some common mechanisms of injury associated with pediatric trauma. And so we know falls are a big one, right? And we know burns can be, thermal injuries can be another one. But we'll talk about the mechanisms of injury with that. Important things, the things that we do well is our interventions. And so we're going to plan appropriate interventions for our pediatric patients. Why do we put a traction splint on? Why do we use spinal motion restriction? Again, so we're going to talk about the various interventions that we have for our peds patients. And then I think one area that we don't where we have opportunities to improve is health promotion strategies related to trauma care and injury prevention. It wasn't until the mid 2000s did I start wearing a helmet skiing because some of us old school people, we like skiing with our nice little knitted hat and this and that. But why did it change for me? Well, it changed for me because I became a dad and I needed to role model, and if I wanted my kids to follow suit, well, I should do it as well. I shouldn't I should practice what I preach. Quite frankly, wearing a helmet, I'm so much warmer And of the one time that I was hit helmet to helmet at Keystone, like 2010, I received a minor concussion. And if I didn't have that helmet, oh my goodness, it could have been worse. So I do think health promotion is really important for all of us. Um, and say it's a cool thing for our kids. So again, we know peds are not just little adults. Working in a level one trauma center, both adults and peds, um, you can't necessarily say, oh, it's just a little adult because, like we said with our objectives, there's significant differences from anatomy and physiology and disease process and state. And so the things that we need to know that 30% of our emergency department visits in the United States are pediatric patients. And that's a pretty good number here. And then as we further talk about epidemiology is, pediatric trauma accounts for 40% of all pediatric visits. And that's a chunk of patients that we experience in the emergency department. So again, we talked about planning interventions, the reassessment, the trauma process. That's going to be really important to think about. And then we know injuries are the number one killer over 1 year. And so trauma, and there's an agency, the American College of Surgeons. There's a lot of data out there, and we, pull our numbers from ACS and talk about, again, injuries are going to be the number one killer. So that's why it's really important to learn how to manage your pediatric patient. Data. Who loves data? Well, it's not going away. And the only reason why I put it here is we don't know how to manage our patients unless we have data and outcomes. And I think, as I mentioned before, with like the American College of Surgeons and we analyze outcomes, right? We want the best for all of our patients, adults, peds, whomever. But number one cause of morbidity and mortality worldwide from peds is, we're looking at this. So if you look at this graph to the right, it looks motor vehicle crashes, firearm related injuries, malignant neoplasm, cancer, drug and overdose, heart disease, drowning fires. So you can see over time, over a 20-year span, from 2000 to 2020, deaths per 100,000 children. And so you can see motor vehicle crashes have taken a dip and firearms have gone up. Cancers kind of went down a little bit. But this is data that we have to come up with plans and how we better mitigate and manage all of our patients. As I mentioned before, with our objectives, falls are the number one common mechanism of injury. And even falling on snow, whether it's powder or hardtack, a groomer, it's a common injury. We know trauma brain injury results almost a 500,000 each year in children less than 14 years of age. So again, think about that kid that bumps his head and has a little, transient altered level of consciousness. And we know head injury accounts for 1 to 2% for all pediatric emergency department visits. So that's still a significant amount. And most of the time, the head injury in the child is mild. They bumped their head. It was great because when my daughter was playing field hockey, she had a baseline concussion test. So we knew her baseline. And if she ever got a head injury and we did a concussion test, we can say plus or minus what was it. Not many places have that ability or opportunity, but again, we know most of these concussions or head injuries are mild in nature. And again, we talked about with our objectives, developmental and A&P differences between children and adults and various ages. And then remember with kids have this compensatory mechanism. The way I always describe it is kids could, compensate, compensate, and compensate, and compensate. But once they get to the cliff and they fall, there's no coming back. And I always relate bad outcomes are from bad assessments. And what I mean by that is, and I've seen in my career, oh, they're fine. Oh, they're fine. They're fine. 2 to 3 hours later, they're on a ventilator now. Well, they weren't fine. Those subtle changes should have alerted us. And now that we have a bad outcome, we miss those opportunities 2 to 3 hours before. So again, that analogy of a child on, walking and then they fall off the cliff, they have those compensatory mechanisms. And that's why I think it's really important to, if there's something, raise your hand, communicate, articulate that to your team, and know that something might be changing with that um, pediatric patient. So again, yes, there are anatomy and physiology differences, right? So we're going to talk about recognizing what those differences are and why it's a critical component in trauma care. And then again, we can have a child, you can come up on scene, and that child might have some subtle signs and symptoms of a serious injury. And that's why it's always important to be on your A game. That's our responsibility as patrollers and healthcare providers. We have to be the eyes and ears and the advocate for that pediatric patient. So again, it might be subtle. Involve the family in the assessment, might be limited to communication. So if there's family or friends around, that's great. I know next month on our mountain, we're going to do the National Special Olympics. And so it's awesome to see these awesome athletes, but they also have some health challenges. And so sometimes I might not know what their baseline is, but their coach or their family or their friend does. And so that's why I think it's going to be essential with what's the difference? What's different now than before? Why did you call us, or what was the situation that we were notified? So that's going to be important when we talk about anatomy and physiology. So the other thing about children, we have developmental concerns, right? And so some of the differences in children that increase their risk of injury, again, they could be easily distracted. There could be limited grasp of cause and effect. They can be difficulty judging speed and distance, difficulty localizing sounds, difficulty recognizing. They could be egocentric and risk takers. I remember when I was younger and I was skiing with my friends at the local ski hill, and I grew up in Michigan. We took the moguls and jumps, and we did so many crazy things, and it's amazing we're still alive. And yeah, we were risk taking, and so that's some of the challenges that we face with the pediatric population, whether they're school aged or a high schooler. There's just so many things that are going on in their life and mind, and so we do know there's developmental changes, especially with the frontal lobe in young men. Again, we talk about anatomy and physiology changes, and why could this increase their risk for injury? Again, think of the little child, large head, more room, right? They can have a thinner cranium. Their fulcrum is at C2 and C3 in their neck, right? They have a smaller and floppy airway, and so that can pose a challenge for any airway management. And again, a short neck. And so does everybody have an appropriate size C collar? And we're not going to get into the weeds about spinal motion restriction, but how do we manage this, right? They might have the inability to increase stroke volume. And again, while this is not necessarily a cardiac lecture, um, their pump is at the same volume, right? But they can increase their rates to compensate, and they only could do it for so long. These kids might have some a protuberant abdomen, so got that little belly going on. And so they might be in the park and they might hit a jump or a rail and hits their abdomen and cause some trauma. And so that can also be a challenge. And then again, we know they have a greater body surface to mass ratio. And so that's also another consideration with anatomy and physiology for our patients. So this is what I tell all of my new grad nurses or new nurses coming into the emergency department or all patrollers. So we've heard of the pediatric assessment triangle. I actually want to change it to the patient assessment triangle. And so what I mean by that is what's my appearance, what's my work of breathing, and what's my circulation. Now they might be all fine in all those three categories. They still have the potential to decompensate. And so again, while there is the pediatric assessment triangle, I think it's important on all patients, sick or not sick. What's your patient assessment triangle? And this is something used, throughout the world with EMS and patrollers alike. And so when we break it down, the pediatric or the patient assessment triangle, it's pretty simple. So I think one of the things that I have to think of first is what's my what's the observations, the interactions, right? And so I think we have to say, are they not sick um to the environment? Do they focus on familiar people and objects? Are they alert for threats? Do they have good brain functioning? So again, all of our kids, they run on sugar, right? And I'm not saying Monster or those energy drinks, but kids need oxygen, kids need ventilation, kids need cerebral perfusion. They need sugar to really ensure that, we have good brain functioning. And again, that sick patient, they don't care if you're present or recognize their parents. If there is a child, an injured guest that is sick, there may be times that they're just they don't care if you're there. They don't care if you're doing a head to toe. They don't care if their parents are there. Those are the kids that I really, really worry about because there's something else going on. I have to, again, be on my A game, but more importantly, do my systematic approach on figuring out what's wrong with this patient. And so that has to be rapid. So as I mentioned before, really one of the first arms of that patient assessment triangle is appearance. So looking at this child here to the right, you know, are they interacting? Do they have any tone? If they're crying or wailing, are they able to be consoled? What's their look and gaze? And while this is not a stroke lecture, are they looking off to the left-hand side or the right-hand side, or do they have a blank stare, or are they totally eyes shut? And then again, what's their speech and cry? Do they have, depending on their developmental age and their age, can they speak to you, right? If it's a really small 2 or 3 year old, and we have 2 and 3 year olds skiing all the time, you know, um, can they communicate with you? And so if there is a family member or a guardian, um, will they settle down with them present, like consolability? So again, looking at an appearance, from afar, you can say, is something going on here? And again, I think when you think about general appearance, it's going to reveal a lot of information, right? I'm going to know, are they breathing and ventilating? And ventilation and oxygenation are two separate things, but I'm going to see, are they ventilating? Are they getting air in, right? And is there perfusion to the brain and central nervous system? The big thing with the general appearance is if there's any alteration, there's a problem. And I'm not Superman. I don't have X-ray vision. I don't have a CAT scan. But if there's something going on, we need a continued thorough assessment on this patient, and that's going to be really important for us. So when you think of appearance, I think of tickles. I'm not going to tickle you, but what's my tone? Do they move their arms and legs? Is there sympathetic tone, or are they flaccid and limp? What are their interactiveness? Is the child interacting appropriately with the environment? Are they hanging out with friends? Are they there with uh, mom or dad? Consolability, I mentioned before, is the child easily consoled or comforted by their caregiver or familiar objects? Again, that look and gaze. Is the child alert, right? Or are they staring off into space? Are their eyes open in response to noise, or are they sleeping? And again, as I mentioned before, sleep and cry. Is the child's speech appropriate, or their crying vigorous, or vocalization weak or listless? You might have a significant injured child who's just has this really weak cry. And, again, we talk about ventilation and oxygenation. It's just like there's air not getting out of this kid and their leg is twisted. That looks like it hurts. And so those are things that I always worry about, that weak cry, or are they listless? Again, the other arm of the pediatric assessment triangle is that worker breathing. Again, you already saw from an appearance, but are they tachypneic? Are they breathing fast, right? Do they have any stridor? Again, were you called to the cafeteria and this kid had a cookie that had peanuts in it and they have an allergic reaction and their stridor? I don't know. Do they have asthma? Are they grunting? Are they trying to create this positive pressure in their lungs to create this PEEP and keep them breathing? Do they have retractions? Do you see that tugging in their neck and shoulders, or are you exposing their chest and you can see the retractions? Again, something easily that you can see with the appearance is any nasal flaring or head bobbing. Are they trying to get that air in? Are they tripoding? This child here in the picture is kind of like a tripod position to open them up. Again, are they using any accessory muscle use? Again, how much is this child working? And again, when you look at work of breathing, look for, any abnormality indicating increased work or ineffective breathing. Again, are they breathing fast? Is there some kind of abnormal positioning? Do you hear audible wheezes or stridor? Again, I don't need a stethoscope on the hill to listen for expiratory wheezes or stridor. I could, number one, with my appearance, see it, but number two, I can hear it through their work of breathing. So those are going to be important things when you evaluate work of breathing. And again, lastly, with the pediatric assessment triangle is circulation. So, is it cold where we ski? Yes. Do we have gloves and mittens on? Yes. There's going to be times we have to remove them, and we're going to look for pallor, right? We're going to look for modeling. We're going to look for cyanosis. Are they blue? Um, it's uncommon for kids to have some kind of dermatologic condition or Raynaud's, and so when you see pallor modeling or cyanosis, that's not good. There's some kind of perfusion thing going on, and so that being said, we need to dig a little bit further. So again, when you look at that skin, look for, insufficient perfusion. So we talked about modeling. We talked about cyanosis or perioral cyanosis. Do they have some pale or ashen color skin? I love using, capillary refills and looking at nail beds and hands and feet. I'm not taking a ski boot or snow boot off on the hill, but I will look at their hands and I will look at their perfusion status and see does it change. And again, the literature says it should change in less than 2 seconds, and so that's going to help me. And again, looking at their face, like I mentioned before, the perioral cyanosis. So here's the thing. So Mark, how do I tell if my kid's sick or not sick? Because I really kind of almost made it binomial, sick or not sick. Well, with the patient assessment triangle or the pediatric assessment triangle, we really have three categories. If there was no alteration in appearance, they were just not talking to you, having a conversation. Their work or breathing, they're breathing normal, they're not fast, they're not using accessory muscle uses, there's no audible wheezes or stridor. And their circulation, the cap refills less than 2 seconds. They're kind of pink, warm, and dry, they're sick. And you might say, well, sick doesn't mean good. And I'm like, well, you could have something going on that we're just not seeing. And so I think it's okay to say, yep, they're sick. Now, if there's an alteration in one of those components, they're sicker. So maybe they have good perfusion, they're breathing normal, but they're just not following commands or directions, then they're sicker, right? But if they have alteration in two or more components, like say their work of breathing's really fast, and say their circulation is delayed and poor, but they can follow commands. An alteration in two or more components, they're the sickest, meaning we need to, do something and we need to get out of here after our trauma assessment, our patient assessment. So when you think of that pediatric assessment triangle, look at your appearance, work of breathing, and circulation. That's going to be really helpful for the foundation of, hey, are they sick, sicker, or sickest? And again, with initial assessment, we always know there's always a scene size up. I love it when I see new um, patrollers or EMT students, scene size at BSI, PPE, how many patients do I have? And so it's awesome. It's get that memory, but that first impression, that's your patient assessment triangle. Again, how sick, how quick are we going to work on this? And then again, we also know with your initial assessment, we got the alphabet. We got our airway, breathing, circulation, disability, and exposure. So again, we're going to immediately treat life-threatening issues and then reassess and then make transport decisions and communicate earlier. If you know you have a really bad patient or scene on the mountain or hill, we need to communicate early. We need to get those resources moving towards us so we could, intersect with them to get them to the appropriate facility. The other parts of the process is, again, further assessment. So again, yes, vital signs are important. Getting a focus history, everybody gets our sample. And again, physical reassessments. And then determine if there's anything that's not life-threatening, can we treat en route? So again, that initial assessment, we're going to make, with our pediatric assessment triangle, treat those immediate life threats. And I think what we've learned over the last, 10 plus years is while we grew up on airway breathing and circulation, we've also known that stopping the bleed, the no pulse, we're going to move the C to ABC. So we might do compressions, we might do, bleeding control. And so know that the alphabet might change depending on the situation or scenario. So again, we know that initial assessment is immediately to identify and treat any life threats. If there is something major going on, we need to stop, address it, and move forward. And again, remember that the level of consciousness changes, which is driven by brain perfusion. So important things about our level of consciousness is, again, do they have the ability to protect their airway, which is diminished? Or is there airway protection may be required for pediatric shock patients? We know shock patients, the perfusion goes down, respirations go up, and if they don't have the ability to maintain their airway, then we're going to have to take control. And we might have to use a non-rebreather. We might have to use a bag valve mask. Important things that we can do and we do incredibly well is we treat hypoxia with high flow, and we treat any causes of respiratory distress with the training that we have. So while someone might be working within the scope of outdoor emergency care and we can bag valve mask or a non-rebreather, great. You might be at a facility or an area that they have ALS providers that can do advanced airways. Great. Again, treat hypoxia, with the tools that we're given and trained with. Please, please, please don't work outside your scope. Going to court wearing stripes or orange is not always a good color on people. Doesn't work with our complexion. So please, please, please work within our scope of practice. So I'm looking at the time. Let's do a scenario. I'm going to pause for a second. Is there any questions so far that we have? I'm going to look in the chat. So far I'm just seeing it's about the attendance purposes for the forms. Cool. So let's do a scenario. And again, my goal is to educate and what are things to learn, and not to trigger anybody or make anybody sad. And so we're going to do a scenario. So I did a little history and I looked at Bear Creek where Eric's at and I got a picture. And here you're called to Broadway towards Family Park where you find a 4-year-old child lying on the ground after a jump in the feature. And so it's kind of like this park and then another area they merge together. And so you're called here. And so the first thing that I like to do is check my brain, check my pulse, slow down my breathing, because sometimes these are exciting times and I don't want to add to the problem or confusion. And so I think it's really important, even for the most experienced provider, take a few moments and just just slow down and just think and go through your process. And that's going to be really important for all of us. So we go to this 4-year-old. So again, what we just learned was our patient or pediatric assessment triangle. Their appearance is unresponsive. Their work of breathing, they're tachypneic, and you see retractions. Circulation to the skin is pale skin color. What do you think? What's your assessment of this patient? That's the proverbial, what's your assessment of this patient? Let me go. So what's our assessment? What do we think?
Head injury, concussion.
Cool. Cool. And yes, someone said family park learning area. Yeah, that's where we get a lot of accidents because people are trying to learn and be cool, and this is a good thing. Critical shock, absolutely. And it could be E, all the above, right? And so it can be a lot of things going on here. So we already know the pediatric assessment triangle reveals this is a critical kid, right? We already had two, if not three, we had three areas. And so this is the sickest patient that you're going to see, right? Again, abnormal appearances to someone mentioned head injury or shock. You're both right. Tachypnea is a response to poor perfusion and metabolic acidosis. Retractions that might indicate some kind of chest injury as well. Because we just did our, pediatric assessment triangle. We still have to do that rapid trauma assessment. And then pale, the skin's pale. It might be due to hemorrhage. So this is again another significant. We know the airway's clear and there's no stridor. Again, with this 4-year-old, and I'm not expecting us to memorize numbers, but the respiratory rate is 40 breaths a minute with good airway movement bilaterally. Their heart rate is 190 beats a minute. Pulse is thready. Your capillary refill is 4 seconds. Remember, I said 2 seconds for, less than 2 seconds. And someone had the ability to get a manual blood pressure of 70 millimeters. Help. So what's our perfusion status for this child? Possible spinal or head. Yep. Was the kid wearing a helmet? I don't know. Definitely a circulatory issue or blood volume. Yep, absolutely. Great. ALS for sure. Thank you. So all great answers. Yeah, this is sick. So we continue with your ABC, the alphabet. The disability um uh is AVPU, is they're unresponsive. We notice is the right pupil is larger than the left and they're unresponsive. And we also know when you expose them, um, the right parietal scalp, there was some kind of contusion. You saw the abdomen was distended and tender to palpation, and they have a right thigh deformity. What do you do? What do unequals pupil indicate? Brain injury, TBI? Exactly. So we already knew they had potentially some kind of blood loss issue. Now we're throwing in a brain issue. This is just a lot. This is a lot. And by the way, these scenarios and these patients are not uncommon. I just wanted to, bring up and raise the level of awareness and spidey senses on how do we manage a multi-system trauma. Here's the other cool thing. When we're done, I'm going to make sure Eric has the ability and Linda have the ability to send you out these slides. So you could use them, massage them, do whatever you want in the future, multiply them so more people could learn and see. I see femur, soft injury, and brain. Yikes. Worst case. Yep. And again, not to trigger anybody, but these things do happen. So again, pupils. And while I'm not a neurosurgeon, I'm a good ER nurse and paramedic. You know, unequal pupils may reflect a severe brain injury, right? And it could be hemorrhage in the brain or some kind of swelling or increased intracranial pressure, and that's not always a good thing. Um, what are likely injuries and initial management priorities? So what do you think we want to do for this? Hmm. What do you want to do with this person? O2 ship, yep. Backboard, call for ALS, transport immediately, yep. Immobilize, treat for shock, monitor breathing, rapid transport, O2, ALS, yep. SMR, yep. Treat for shock, bye-bye. 100%. I'm on the radio with my dispatch saying, I need the cavalry here now. And again, I'm not going to necessarily talk about, you know, uh, vernacular or verbiage wherever we're at in the world. I just know I need the cavalry here with all my toys and all the people that can help um, to help manage and get this person off. I also will be like, hey, I need flights on, on scrambled or standby if weather is good because they're going to have to get to that trauma center, and so that's going to be really important. So yeah, exactly. In all of your answers in the comments were perfect. So again, what are the injuries? And you already nailed them. They have some kind of TBI or some kind of brain injury, probably some kind of abdomen injury because when you expose their abdomen, it was tender and it was distended, and then a femur, some kind of long bone fracture. And for a 4-year-old to break a femur, that's a lot of kinetic energy. We can do an hour lecture just on kinematics and kinetic energy. But our management priorities are, someone mentioned already, spinal motion restriction, open the airway, right? Suction as needed. Again, head injury people, nausea and vomiting, they throw up. So have suction available and use that if needed. Assisted assist with ventilations as needed. Um, Again, if they're having good respiratory effort, yet with 40 times a minute, they might just have a non-rebreather. Are they ventilating well? If they're not, we might have to assist them with a bag valve mask because these changes in respirations might happen. And we'll talk about some challenges with that. Clearly control any external hemorrhage, immobilize the injured extremity, and rapid transport. We were talking about traction splints the other day, and with our Denver Metro protocols, the only time we wouldn't is if there was a contaminated bone sticking out, and that was kind of a gray area because the discussion we had with patrollers and some of the physicians that wrote the protocol said this is kind of a gray area. If there's benefit for a good immobilization, then go for it, or call medical control. But some kind of immobilization of the extremity so it's not flopping around, that's going to be important. I'm also going to default by saying follow your local protocols. So Copper Mountain, Colorado uses the Denver Metro protocols. Pennsylvania, Bear Creek might use one type of protocol. Blue Mountain might use one type of protocol. I'm going to say default to your own. So there's not necessarily a big broad brush, but these are priorities that have an overarching, hey, these are the things that we need to do to take care of this child. Again, BLS priorities, right? If you have the ability for airway management, continue the bag valve mask. Again, where I work, all of our patrollers have the ability to use an eye gel. It's great if properly used, and especially if the child loses their airway. If you have the ability to obtain IV or vascular access, we can do this en route. We don't have to stay and play. And that's what I tell all my doctors and nurses and paramedics. There's a lot of things we can do en route. But if we are going to consider vascular access, we can do fluid resuscitation. We use 20 mLs per kilo of normal saline or lactated ringer. Um, and it should be warmed. We have warmers. And so again, this can be done en route. And if you have a cardiac monitor, great, apply it to the patient. These are things that you can continue for that. So here's our Glasgow Coma scale. Um, I don't know one person that has memorized this, not even some of the best neurosurgeons. And that's why we have these posted in our resuscitation rooms and trauma bays. But if you can get a GCS, that would be great. Um, Remember, people that just show up, not moving, not talking, no breathing, nothing, they get an automatic 3. You and I right now, we're at a 15, maybe a 14 if it's the end of the day and we're a little tired or you need some coffee. And the good news is we'll have a little bio or coffee break here in a little bit. But GCS is another important tool that we could gauge their level of consciousness, their level of responsiveness. And again, this is just as a reminder for us. So traumatic brain injury. I saw in the chat earlier, some people wrote TBI. Absolutely. And again, there's associated with clinical symptoms, right? So that child might have a brief loss of consciousness. A patient might be disoriented. They might have vomiting. A mild traumatic brain injury, usually the GCS is between 13 and 15, and we measure approximately 30 minutes after the injury. And then there'll be subsequent reevaluations. Again, we don't just take one set of vitals. We need several data points. And so we'll continue to assess and reassess our patient. But GCS, level of consciousness, should be reassessed with every, blood pressure, heart rate, temperature, respirations. Moderate TBIs, initial GCS might be between 9 and 12, and then a severe TBI is GCS less than 8. And for those that are ALS or advanced life support, we in the medical world say GCS less than 8 intubate, meaning they can't um, maintain their airway safely. And so I think that's going to be something to consider. But I think TBI is going to be really important um, for us to know. And I think it's good to remind ourselves with with all of our patients, besides your AVPU. Again, we can calculate the pediatric GCS. We're going to check pupillary response to see if there's a unilateral dilation. We might be concerned about herniation or compression of your cranial nerve 3. They might have nystagmus, meaning some kind of cerebellar injury. Loss of consciousness with the injury. So, in brief, the patient may not be aware and witnesses may not have noticed. Remember that the patient may report inconsistent and be unreliable. Did you lose consciousness? I think so, maybe. It might not all be there. They can have some temporary amnesia or confusion about the event. And so these are things, with your neurological assessment, that's going to be important, especially with the pediatric GCS. And again, I'm not expecting you to do a neurosurgical assessment with all your cranial nerves and everything, but I think just having what's my pupils looking like, what's my GCS, again, concerns if there is loss of consciousness for the patient. That's when we need to communicate to the rest of our team or during handoff, what were the initial findings? Did anything change en route, right? So high risk signs and symptoms, right? And so what's really important is there an abnormal neuro exam? Do they have some kind of visual disturbances? Do they have some focal neurologic signs? Are they even seizing on you? That's something that I get really worried. Like seizures, not normal. Do they have a history of seizures? I don't know. Do they have seizures? Yes. Bumping your head and having a seizure is it's not a good one. Prolonged loss of consciousness. The child might be down. You arrive and they're still unconscious. That's significant. What kind of depressed mental status do they have? And then do they have any underlying conditions, predisposing some kind of head injury? So do they have a clotting disorder? My niece, she has von Willebrand's, and so she has some kind of bleeding disorder. And so anytime she gets a cut or hurt herself, it's a concern, right? Do they take anticoagulants? We have um, kids that have different structural heart diseases that they take blood thinners. Like, what? What do you mean the kid takes a blood thinner? I don't understand. Hey, there's things that we need to know that through your sample, when you do your history, it's going to be really important to find out. Again, causes of respiratory, right? And so with kids that have head injury, what I need you to walk away is think airway, oxygenation, C-spine stabilization or SMR, and have suction available. Because some of these neurological issues with this depressed level of consciousness, it can lead to some kind of upper airway problem or some kind of protective airway. And so that's going to be a concern for all of us because the last thing we want is this child to be breathing, talking, their depressed level of consciousness, they can't manage their airway, they vomit, and then they aspirate in the lungs. That's going to be much more of a challenge for that. And again, sometimes there could be a transection of the spinal cord leading to paralysis and loss of upper respiratory muscles. What we've learned a long time ago is C3, 4, 5 keep the diaphragm alive. So if my neck is broken, my diaphragm's not going to help me breathe, and I'm going to lead to impending respiratory arrest. And that's why having your bag valve mask available, and that's why having your portable suction available, it's going to be important. And again, that patient might have some kind of midbrain or medullary contusion affecting respiratory, which can reduce their breathing rate or cause periods of apnea. And so, Eric, this might be a good area where we can stop and then we can come back if that's okay with everybody's time. And I can stay on and answer anybody's questions that you might have while people get a bio break or a cup of coffee.
All right, so let's do that. Let's pause, take 10 minutes. We'll come back at 8:05.
Excellent. Can you see my slides?
Yep, I can see your screen.
Excellent. So we ended on head injury. We ended on the causes of respiratory failure and in children with head injuries. And so let's talk about head injuries. And again, I think the foundation we need to lay is let's go back to school a little bit and do a little anatomy and physiology. And I think that's why that's important is we need to look at literally, the brain here. We need to see the gray matter. We need to know that there's arteries. We need to know that there's veins. And really, when you look at the top level, you have the dura matter, and then you have the arachnoid matter. There's that subarachnoid space. There's veins in theirs. We also have the pia mater, and then various vessels. So I think just from a side cut of brain, it's really important to think about our brain and the different layers that we have. And when we dissect it a little bit more, we're going to talk about several types of brain injuries. We'll talk about the epidural hematoma. And here's a picture of the epidural hematoma where there's a brain injury, which results where there's a collection of blood between the skull and the dura mater, right? And so usually these are fractures within our temporal and parietal bones that lacerate the middle meningeal arteries, okay? And there's quick bleeding into the brain. Important things to know, these are immediate surgical interventions are needed. And if you are within 2 hours, the literature tells me if you're within 2 hours of a neurosurgeon and you've identified that this is an epidural hematoma, prognosis is excellent if treated earlier. But again, you need a neurosurgeon, you need a CAT scan, and these are things that happen from the middle meningeal arteries. So this is, a brain injury, boom, with or without a helmet. And again, do helmets prevent bleeding in the brain? No, they reduce the amount of kinetic energy and hopefully not as major. We'll continue to preach, please wear a helmet, please wear a helmet, please wear a helmet. But with epidural hematomas, there's bleeding. And so when you look at a CAT scan, and I think it's always relevant to put some slides up of a CAT scan, this patient may or may not have decreased level of consciousness. They may have an initial decrease, and then there's this lucid period, and then rapid, and then worsening. So the person might be, they bump their head, they're a little unconscious, and then they wake up, and then they go out on you. That lucid period, every time that I've seen it, it's majority of the time have been an epidural. They might have some hemiparesis on the opposite side of the hematoma. So if I'm looking at this CAT scan right now, and when you look at CAT scans, you just conceptualize looking from the feet to the head. So on the left-hand side of this slide, it's actually the right-hand side of the patient. On the right-hand side of this slide, it's the left-hand side. So when I say they may or may not have hemiparesis or hemiplegia, the left side of the body, their arm might not be moving, their leg might not be moving. And so they may have also unilateral or fixed dilated pupil on the same side of the hematoma. And so these are things to think about with your epidural. Again, I'm not going to have us diagnose on the hill whether they have an epidural or whatever type of bleeding in the brain. I just know something's going on. They need a trauma center. They need a team of other experts to help manage and care for this patient. I think the big thing that, to know is they might have this lucid period and then rapid worsening in level of consciousness for your epidural. And again, we mentioned before the prognostics are great if treated immediately because bleeding can't continue and continue and continue. The other important thing about this CAT scan picture here, white is bad. White is blood, and that's not a good thing. And if you can see in the center on the bottom, it looks like a number 1. It's being pushed to the right. That means the brain is getting pushed to the left side of the bleeding is pushing the brain on the left side. So that's adding intracranial pressure to the brain, and that's not good. Subdural hematoma, again, another focal brain injury between the dura mater, right, that leather area, and the arachnoid layer, resulting from probably some kind of acceleration and deceleration or some kind of combined forces. These are more common than epidural hematomas. And usually it's from a tearing of the veins inside. And it could be a direct blow to the brain tissue. And again, it's venous in nature from those bridging veins. Remember, epidural is usually the middle meningeal artery, and the subdural is from kind of bridging veins. Again, here's another picture of a CAT scan of a subdural. Again, this patient may be acute or chronic. When we see subdural hematomas, usually they're in elderly patients. Usually they're on anticoagulants, blood thinners, any of the Pradaxo or warfarin, Coumadin, or Xarelto, or any of those things. It could be a chronic alcoholic user. So someone that is a daily drinker that drinks a lot, they walk and they bump their head and they think they're intoxicated. Well, it might not just be that they're intoxicated. They might have a subdural hematoma. And again, these are actually more lethal than most other brain lesions. Why? Because sometimes it's chronic. Why? Sometimes it's an elderly or person that, was an alcoholic user and they bumped their head and they showed up a couple weeks later and now the brain is full of blood and they've been compensating for some time and sometimes we just have bad outcomes. So again, remember, if we're looking at this picture from the feet to the head, on the right-hand side of the brain, you see that blood and it's occupying space, and that's not a good thing. Again, the person with the subdural hematoma, there's a steady decline in their level of consciousness. They can have hemiparesia or hemiplegia on the opposite side of the hematoma. They may or may not have unilateral or fixed dilated pupils on the same side as of the hematoma. So if I'm looking at this CAT scan, this person's right eye might be fixed and dilated, and so that's another thing that can help me out with my neurological assessment. Yes, I'm going to get a Glasgow Coma scale. Yes, I'm going to look at their pupils. On my vest, I have a little pen light, so I do pupil response. And so I think that's going to be another important assessment that we do on the Hill. And here's the thing for my second grade education. I'm not a CAT scan expert, but this is how I differentiate. Is it a subdural or epidural? I'm with all of my trauma patients in the CAT scan, and I love our CAT scan techs. And sometimes I'm looking at the screens while it's live and the trauma team's behind you and they're looking and they're looking. And so to make sure I know what I'm looking at, when I see the banana or the lemon, I can differentiate kind of now. Is it a subdural versus an epidural? And I think these are things that, let's elevate our practice. Let's kick it up a notch. And I think that's why, let me get the best. That's why I think when you look at how you differentiate, again, is it a bridging vein? Is it a subdural? Do we have that concave or crescent shape? Or is it more of a convex or a lens shaped? And again, could it be related to the middle meningeal artery? And again, that's going to differentiate the type of care that they receive. Are we going to the OR now and cracking the egg and evacuating blood? Are we, taking care of a vessel, or are we going to do some observations for a little bit? So the other one that we'll go into the last, and there's a couple other types of brain lesions or hemorrhages. And the other one is subarachnoid hemorrhage. And again, this might be related to trauma. Again, this could be a sudden excruciating thunderclap headache, often a popping sensation or stiffness in the neck. There might be, blood leaking around the brain, typically from a ruptured aneurysm, and they also require immediate emergency care. And so I think these are important things that, okay, is this an aneurysm that bursted, or is this an aneurysm that's putting pressure and is leaking? How are we going to manage it? And when you think of the anatomy and physiology, you think of that arachnoid and that pia mater and the blood in between that's leaking out. And so when people have this excruciating thunderclap, remember that blood is everywhere in the brain right now, causing pressure and pain. And so they need immediate neurosurgical interventions. Again, someone's going to say it's the worst headache they ever had. There might be some nausea and vomiting. They might have this ataxia or change in level of consciousness. They might even have a seizure, coma, and death is possibility. And remember I mentioned from the CAT scan, white is blood and bad. If you look at this CAT scan, it's kind of like a star. There's white all over. There's blood all over. And so again, that's the blood leaking in the subarachnoid space. And so when we're in the CT room looking at our trauma patients and you see it show up, you're like, no, we got going to the OR or whatever the neurosurgeon prefers. We can move forward with that, which is great. Important things to think of is, okay, we got this kid, brain injury, right? So there's a thing called Cushing's triad. And basically the triad is three things, right? It's bradycardia. My heart rate is slow. It's slower than normal. Again, you and I right now sitting here, we might have a heart rate between 60 and 100, right? It might be 40. It might be 38. So they might have some slow heart rate. They also can have this hypertension. So blood pressure is elevated. And so if we're getting that manual blood pressure, they might be 190 over 110. So again, that's not normal. And so their blood pressure can be elevated. And I call it alteration in respiration. And again, this is a late manifestation indicating some kind of herniation. So again, when we think of, alteration in breathing, they may be hyperventilating, be breathing fast. They might have some Cheyne-Stokes or apnea. I just know that my respirations are not normal. It's not, hey, we're relaxing and breathing normal. I know there's something going on with my respiration. So elevating your practice to say, hey, their pulse is 40, right? Their blood pressure is really high, and that top number, the systolic, is pretty wide from the diastolic and irregular respirations. This person has probably Cushing's triad. And so again, these are other things that you can provide in your assessment documentation and handoff to say, hey, I believe this person has Cushing's triad. And again, this is something to raise awareness. Again, going back to our 4-year-old here, right? So during transport, the child color improves with initial intervention. So yes, you gave oxygen, right? We had suction available. We probably splinted a leg. But there's no change in the right pupil. So remember we said that right pupil is big. What additional treatment measures are indicated at this point? What do you think? So you really got a big sick kid here, and that pupil hasn't changed. And I'm scared. And it's okay to be scared. Oxygenation, yep. Are pulse oximeters reliable in smaller patients? Great question. As same before, O2 in transport, yep. Monitor for shock. Keep warm. Yes, yes. It is cold. Keep them warm. And we'll talk a little bit later about that. So yeah, excellent. So things that I want us to be aware of. So pupils. So A, B, C, D, disability, de neuro. Children with fixed, dilated, or unequal pupils may show signs and symptoms of some kind of serious head injury, and we might need a little bit of hyperventilation. And so again, this is a 4-year-old we talked about. We might have to increase their ventilation if we're bagging them to 25 breaths a minute. So if we're thinking 16 to 20 breaths a minute normal, with this dilated and fixed pupil, we might have to increase it just a little bit, just a little bit. So after hyperventilation, so 25 breaths a minute, right? Just a little bit. The child's right pupil constricts. The child's heart rate and blood pressure and level of consciousness improve, which is a good thing because that's what you wanted. What additional management priorities during transport? What else do we need to do for this kid? And let's consider this is your longest run at your resort. So you're like, we're not at the base. So, what are other considerations? Alert upcoming care? Absolutely. Continue transport, call for ALS, medevac on standby? Absolutely. Closely monitor? Yes. All great answers. So let's talk about some advanced concepts. So, by the way, all those answers, all correct. But let's talk about some advanced concepts because we're not just patrollers, we're healthcare providers. We really care what we do. And I honestly, at the end of the day, we don't have a choice who shows up. They show up and we have to respond. And so that's my openness to how we manage care. But some of the advanced concepts that I want us to be cognizant of is let's talk about the trauma diamond of death. It used to be called the trauma triad of death, but now it's the diamond. And this is a concept describing 4 interconnected physiologic problems in severe trauma patients. So you already knew this is a trauma patient, despite the head injury, right? But you already knew this is a trauma patient. The leg injury, right? The abdomen injury. And so when we talk about the trauma triad of death, we're talking about hypothermia, acidosis, coagulopathy, bleeding problems that we have, and hypocalcemia. And again, that create a deadly worsening cycle leading to uncontrolled bleeding and shock. And so I just want everybody to be aware that there's a thing called trauma diamond of death. And there's things that you and I can do right now to prevent worsening outcomes or bad outcomes. There's 4 components of the uh, uh, diamond of death. Hypothermia, we know lower body temperature slows enzyme activity and impairs clotting. So a cold person, they clot different, they bleed longer, and bad outcomes, and even less than 95 degrees Fahrenheit. Acidosis, So low, if you remember basic chemistry, our pH. So a low pH from shock and poor perfusion hinders clotting factors and activation. And someone mentioned, poor perfusion earlier in shock. Absolutely. Coagulopathy, again, that's that blood's ability to clot is impaired, and they have some kind of bleeding disorder. Like my niece, she has von Willebrand's, and so she has a bleeding disorder. And then hypocalcemia, we know that there's low ionized calcium levels disrupt some heart function and vascular tone, and really the clotting cascade. And that could be another day of talking about bleeding. And also is often worsened by citrate in blood transfusion. So we got to be cognizant when we do give blood to patients that what's their calcium? Do we add calcium? So again, when you think of the trauma diamond of death, the four components are hypothermia, acidosis, coagulopathy, and hypocalcemia. What do you think you and I can prevent? What can we prevent? I can't prevent my niece having a bleeding disease. Hypothermia, hypothermia. Yeah. Warm the patient. Yeah. Hypoxia, control bleeding. Absolutely. All right answers. All right answers. Um, so what can we prevent? Yeah, acidosis. Give them oxygen. Give them O's. Give them O's. Keep them, make sure they get oxygen. And hyperthermia, keep them warm. So in our code packs or trauma packs or whatever, we have these little packs that we bring to our patients. We actually have click it heats. And it's pretty cool because a click it heat, it's about size of a piece of paper, a little bit larger, and it's plastic. And you click it, and then all of a sudden it solidifies and heats up. And so don't put it on bare skin because it'll burn you, but put it between um, their shirt or pants to keep them warm. Usually we put it on the thorax and abdomen, and that helps. They love it because it's cold and they're sick and they're injured. And so if you have some kind of warming measure, keep them warm. That's great. And then obviously we already talked about giving them oxygen. So all your answers are spot on. Is there anything else you want to do? So you gave them O's, you kept them warm, you put flights on standby. Treat for shock. Splint will help control bleeding. Yep. Body position. Absolutely. Monitor vitals. Yep. Yeah. Vitals, vitals, vitals. Love it. We can have a dedicated patroller just to do vitals. Absolutely. So I think transport priorities are important for us, right? And so you've done your reassessments of your patient assessment triangle. You've done your ABCs. You did your pulse ox, and if you had EKG monitoring. You prevented hypothermia by the means that you had available. You could defer the history and physical exam and detailed physical exam. A lot of times we can do that en route. And so when you have a really sick patient, it takes a few moments to get sample. It takes a few moments. Again, don't miss anything. You may consider an ALS intercept. Are they going to be at the bottom of the base in the mountain to take them away from you and not go to your aid room? Is a helicopter coming? These are things that we need to consider for transport. And again, getting early on the phone. When we have really bad sick patients at Copper, we have a dispatcher and we're like, any the really cool thing is, this is the neat thing. Any patroller, even if it's a rookie patroller, says, I want lifeguard 2 or flight for life, they'll get it. There, no one will question their call. And so, and there's no hierarchy. You don't need a senior patroller. You don't need, the old man Mark or an ALS to say, oh, no, you can't do that. If you want flights, you get flights. End of discussion. And that's our culture. in our practice. It might be different than around the nation and world, but think about your transport priorities. With your transport priorities, I think it's important to raise the awareness of, okay, where are we going? Where's my child? Where's my loved one going? I mentioned much earlier, American College of Surgeons. There's a thing called Committee on Trauma. We know that there are verified trauma centers. American College of Surgeons are the gold standard for trauma care. Are there states that have a state trauma registry and system? Yes. Um, and not saying anything different than the states, but if you have a verified ACS, that's the gold standard. At the end of the day, a child like this that you just experienced needs to go to a level 1 pediatric trauma center. That's where the best and better outcomes are. If there's not an available pediatric, there are some states like North Dakota and South Dakota, they don't have a pediatric verified center, which you're like, what? What do you mean the state doesn't have it? They don't have a verified level 1? Nope. They might have a 2 or 3, but the highest level of care for a child like this needs a pediatric level 1. Now you might say, hey, Mark, we don't have a pediatric level 1 near us. That's okay. We can go to a level 1 adult trauma center. Much of the adults, their training and experience and resources have the ability to manage pediatric patients. They could, manage care for the initial injury and insult, and then figure on the short and long-term care with rehab and continued care, and then eventually transfer to the other appropriate facility, like a pediatric level 1, or consult with a pediatric level 1, and then go to rehab or intensive care, etc. If there's not a level 1 adult trauma center to manage, is there a level 2? And then the difference between, regardless of adult and pediatric, the difference really, one of the major differences between the level 1 and level 2. And again, Linda, please come in because I know you've been a reviewer as well. So correct any inaccuracies I might have. But when I see a difference between a level 1 and level 1 and level 2, are we putting some peer-reviewed literature and science out there? Are we producing? It's not to say the level 2 can't have a phenomenal trauma system and center that there's literature and research, but it's really the level 1s that are producing some of these mass knowledge and pearls of care. And with in regards to level 3, a lot of that is stabilization. Can they get to another verified center for high level of care if required? It was interesting. Many years ago, I worked in a level 3 trauma center in Detroit, and we almost called it like a level 2 soft, because we had phenomenal ortho care, phenomenal neurosurgical care. And, our surgeons were great, but at the end of the day, per the ACS guidelines, and I think it was, I forgot what color book it was, we were level 3. And again, we did a lot of great stabilization. The busiest level 3 trauma center in the state of Colorado is Frisco. It's right next to Breckenridge and Keystone and A-Base and all that. So they're busy. They're busy, 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 busy. The second busiest level 3 trauma center in the state of Colorado is Val Health. Again, they have this big mountain in front of them and all these patients coming down, and so they're a phenomenal level 3. But when we see a patient like this, the highest level of care that this child should go to would be a pediatric level 1 trauma center. If that's not available, well, is there an adult level 1? And then go down the numbers. Linda, did you want to add anything to that?
Just that the other capability for a level 1 is really the multi-system patient who needs a surgical intensive care by surgeons. And so your multiply injured, multi-specialty type patient is really best for the level 1 trauma center. But you're absolutely right. What you said, Mark, is spot on.
Thank you. Thank you. And again, these are great places. So critical concepts, I think, highlighting things. Again, we know most of our pediatric traumas result from blunt trauma and not penetrating, which that's a good thing. And when I say a good thing, I think of the knife and gun club where I work. But most pediatric traumas are from blunt. Again, compromise in oxygenation and ventilation are relatively common. So again, ensuring that great initial assessment and do we need to assist them? Again, compromise of perfusion is less common, but it's an ominous sign. Once we see that there's a delayed cap refill or cyanosis and just lack of perfusion, this is a bad thing. And so how do we manage that? Two major causes of early death in pediatric trauma victims are usually airway compromise, so let's manage that airway, and inadequate volume resuscitation. And it's I'm not going to get into a lecture of blood or whole blood, but they need an airway and they need, fluids. And so that's going to be really important with your PEDS patients. Again, keys for success is, that rapid trauma or cardiopulmonary assessment, right? Prompt establishment of effective ventilation. Can we ventilate the child? Are they getting oxygenation? What's their perfusion status? Those are going to be important things that we get. And you could see here a nice team, a picture of people managing an injured guest and getting ready to transport. Um, those are going to be things. Well, and let's continue to talk about success. The important thing about pediatrics is let's use a length-based resuscitation tape for fluids and medications. I'm not going to guess whether you use, there's different length-based resuscitation tapes. And so a common one is Broslow, Hand TV. I think having something objective and measurable to manage this child with fluids and medications is important. And as I tell new nurses and paramedics, you need to learn how to work to the right of the decimal point. A difference in a decimal point might be the difference between giving the right dose to that child, and that's going to be really important. Again, you already know that immobilization as appropriate, and we already had some sidebar discussion on the break about, when you can or can't um, transport that pediatric patient to a trauma center if possible. And again, it might not be possible. And again, you hit it on the nail, keeping that child warm, finding warming measures for that kid. But wait, there's more. It's not just the pediatric kid, multi-system trauma. It's not just brain injuries. As I mentioned before, pediatric injury prevention. And I think this is where we can really highlight our skills to our public, especially our kids. If I don't, if I recall, January is safety month, right? And so I guess the question, what are we doing at our respective places? What are we doing for safety fest? What are we doing for injury prevention? And I think things that we need to teach our kids and families, fitness is important. Warming up is important. Hydrating is important. Proper gear is important. Skills, awareness, techniques, following rules, and then environmental management. Again, educating our people, staying on trails and avoiding hazards. It's always great when you drop a gate and there's fresh snow, but there might be some people, oh man, I want to poach that, I want to ski that. Well, it might be not skiable. There might be some kind of risk. And so that's the other important thing. Someone wrote the bar down. Absolutely. I'm a bar guy. You know why? Because at least where I'm at, there's a little rest for my feet and they just don't get to dangle. They just get to rest. So, and unfortunately in Colorado, historically, we've had some people fall from the chairlift and died, and we've already had several this year. And so we'll see what the outcomes with those are. But I think injury prevention is another responsibility we have to our peds and our families that we see. Especially, I always tell people, know me before I get to know you. Come by our booth. Hey, get some swag or what have you. So again, with injury prevention and response, again, physical fitness and warm-ups, again, this is how we prevent injuries and strains. And research shows that warm muscles are less prone. And again, not just for us, but kids. If there's a ski or a snow group coming up, it's also, hey, let's get involved. Proper technique and posture. Again, correct movement pattern reduces ACL injuries. And this is really crucial. I mentioned before hydration and nutrition. Again, let's prevent fatigue or any cognitive impairment. Again, kids run on sugar. Make sure they're hydrated and they're eating, healthy snacks and foods, and that will help their decisions when they're out there on the slopes with us. There's more. So again, helmet use, proper fit. I've seen so many people with an improper helmet that I have to come up to them and say, "Hey, your helmet's on backwards." They didn't know it. Is it properly buckled for support? Do they have good gloves and mittens? They have goggles for visibility. True story, about 10, 15 years ago, I have two friends who are neurosurgeons, really well known, and they both owned homes in Breckenridge. The second one that bought a home, um, he went on the hill with his kids with us and the other guy, and his kids um, had swim goggles and bike helmets. Bike helmets and swimming goggles. Unfortunately, I didn't have to open my mouth. His partner did. He's like, "You're a freaking neurosurgeon. And you have bougie clothes on, but you have like you're embarrassing me. You go back and you buy your kids the proper gears." And sure enough, um, the kids finally got right helmets, right goggles. But again, this is a neurosurgeon being cheap. Like, you just bought a couple $1 million home in Breck and you're showing up. Like, no, you need to have the proper gear. And that was kind of, we still giggle and talk to about that this day. Again, I think about physical prep. We talked about warming up and staying hydrated and pacing ourselves. Again, technique and awareness, can we stop? Can we stay within our ability and be aware of other choices? Um, and safety rules. I think we have to follow our responsibility code and avoid, closed trails. And with that, we know over the years the responsibility code was expanded. It used to be what, crampons, if I remembered, and now we've added it. And again, this is just really important. And I think we can share this with our family members and pediatric population and just really communicate with them and ensure they have a level of understanding and to make this an enjoyable experience. Pediatric injury prevention, again, wear a helmet, role model. That's what I did. These were my two kids. Oh, I think this was 2009. We were at the Whale's Tail next to we were on peak 8, but we were going to peak 7. That was kind of cool. So here's the data. I told you about epidemiology earlier. Studies show that helmet reduce non-serious head injuries such as minor concussions, but nearly 70% in the 2017 season in the 17 seasons between 1995 and 2012. However, there was no change in the number of fatalities. So like I said before, a helmet won't, prevent you from dying, but it will reduce the amount of head trauma you might have. Again, here's the other crazy thing. Reviewing more than 2,000 death certificates, the average was a 45-year-old male, and I forgot to put male died skiing each year with the average fatality traveling at a high speed on a blue run who collides with usually a tree. So, you got that young dude or a father, "Hey, I'm going to rip this blue run," not even a black run. They get out of control. They hit maybe a patch of ice, skier versus tree, bad outcomes. So again, I think skiing within your ability, not showing off, these are important things that we need to consider. Ski helmet safety, again, choosing the right helmet, fitting it right, and just, it's paramount for preventing serious injuries. Here's the cool thing, the Italian experience I want to mention to you. We're less than a month away. Safety first. So we know helmets are now mandatory for all ages in skiing and snowboarding in Italy. Why did they do that? Italy wants to use the 2026 Winter Olympics in Milan Cortina to send a strong signal about safety. So this is the first country in the world that mandates helmets if you're going to use any of their snow sports. Minors have been required to wear helmets since 2021, but now the law applies to everyone. This makes Italy the first country to introduce such a rule. And then again, if you're caught without one, you can face a hefty fine or possible ski pass suspension. This is revolutionary. This is awesome. It's kind of like seat belts are mandatory in the United States. Well, then why aren't helmets? And so that's something I think we can ponder, that this Italian experience is, to me, I think another positive injury prevention strategy to demonstrate to the world that their family members and friends who ski and snowboard in Italy is important to them. And lastly, I have a couple more slides and we'll wrap up. So again, I mentioned earlier, didn't want to trigger anybody, but we do see some bad things. And so with some of the bad things that we experience, it's important to mention that there's critical stress incident management. So CISM. And we know if you haven't been involved in a bad wreck or scene, it's a multi-component system of interventions and education designed to help us, especially us first responders, to manage the psychological impact of traumatic events using strategies from pre-crisis preparedness to post-incident support, aiming to mitigate stress effects. Again, accelerate our recovery and prevention long-term issues like PTSD by offering psychological first aid, debriefings, and ongoing support. Again, the goal of CSM is to help us return to our previous level of functioning, to get back out on the hill and have fun, to develop better coping skills, and prevent lasting psychological harms from traumatic incidents. Again, you could, you know, see a lot of us have different experiences, and this is just another intervention that helps us. It's really important. Again, as a care provider, we're not immune to any of this emotional or physiological consequences of caring for patients or even witnessing a death. This can be long or short term. And again, some of our experiences might be difficulty concentrating, inability to sleep, repeatedly playing the incident in your mind. You might have headaches, or just this GI problems, or just sadness or depression. We're human. We're normal. This happens. And so it's recognizing that something went on, and how do we get for help and seek help. And the team and a system helps us with this. Again, there's professional help who may need assistance working through the aftermath of some kind of traumatic incident. Some of our agencies have formal agreements with local critical stress management teams for this very purpose. If you find yourself disturbed by an incident, seek assistance. Get help. It's important. This is a good thing. Again, a critical stress debriefing brings us care providers together and train professionals to talk about our feelings. How do we move forward? It can help us understand our stress. You might be home and a little bit short with your family or friends, and this might be related to the scene that you had. And so getting professional help is really important. Here's the great news. The Eastern Division National Ski Patrol has information for patroller stress and awareness, and this is on the website up here. And like I said earlier, both Eric and Linda will have a copy, and we can distribute these slides to you accordingly. But to know that there's resources out there for our stress awareness, and what do we do? I can personally tell you, a couple years ago, well, let me use a stat. So for every million skiers, there's usually one death. Usually it's trauma. And if you think of Val, they have 2 million skier visits a year. Copper has 1.8. Breckenridge has 2 point something. Keystone might have 1.5. A Basin might break 1 million. So a lot of skiers and potential deaths. There are some years we see nothing. But a couple years ago, we actually had 6 deaths on our mountain. 6. And 4 out of the 6 were traumatic, like bad juju, either falling off a cliff or skier versus tree. And then the other 2 were medical in nature, cardiac arrest for heart disease, both of them. So just imagine a new patroller who's 22 years old, just got their EMT license. Maybe they had an okay clinical, and they just have never seen this. This is kind of crazy. And so the good news is, and I didn't get into the weeds what we have for resources, but we have various networks. But to bring this to light, the Eastern Division National Ski Patrol having their patroller stress awareness is just another way to figure out, hey, what do I need to do? What resources? How do I get help? And these are important things. On this slide, you'll see Patrol Stress Awareness Forum takes place the second Wednesday of each month at 7 o'clock. And so here, there's a link and a click that you can go to. And I think this is another great thing that we as ski patrollers get to share and experience. And so hopefully, we see nothing too crazy, but know that there's resources to help us. And again, it's normal to have a headache or to be depressed or concerned, but it's more important to, okay, I got an issue. And like Eric's quote, seeking help is not a sign of weakness, but a sign of strength. That's important because we want you to get back on the hill again. We want you to provide care. And this is just another thing when I think of resiliency and how we manage. So let's kind of bring this to a close here, because you've had almost 2 hours of hearing me, and I'm sorry about that, but I'm happy to be here. Really, I am. Again, we know there's different anatomy features of children that predispose different injury patterns, right? We talked about the shorter neck, the bigger head, the bigger surface ratio, the protuberant abdomen. We know that following the pediatric assessment triangle and initial assessment, again, you need to perform those life or limb saving interventions immediately and transport, get on the horn to get your resources and to get the rest of the team to help you out. Again, you might defer further history and exams with any child in respiratory failure or shock. Again, focus on that bag valve mask, focus on keeping them warm. We talked about hypothermia, right? We talked about acidosis. And so those are things from the trauma diamond of death that you could help and manage. Again, focus on that critical information. Concentrate on that physiology of that, that injury. Establish your ABCs, that airway, breathing, and circulation. Remember the basics. Yeah, I may be a nurse and a paramedic, big deal. And this is what I tell all the paramedic students. In order to be a good paramedic, you need to be a great EMT. That extra stuff, the drugs, the monitor, all means nothing. The basics, airway, breathing, circulation, splinting, good assessment skills, getting a set of vital signs, repeating that vital signs, getting several data points. Again, the basics, I tell everybody, even at where I'm at, BLS saves lives. You can be the best ALS provider, but if you don't have that team that could transport appropriately and promote injury prevention, I don't think you have enough then. And again, I like to distill it down. Keep it basic, keep it simple, right? And then I think lastly, questions. I hope everybody has a great season. I hope you got some information out of this talk. A lot of information, a little bit amount of time. I'll be happy to answer any questions that you may have. And then I'm sure Eric and Linda can provide my contact information if anybody has anything extra, or hey Mark, what about this, or what have you. If you don't want to put it in the chat, I'll be more than happy to communicate that to everybody.
Mark, you've got a question in the chat regarding suggestions on how to first approach younger kids to overcome stranger resistance and obtain a more accurate firsthand assessment.
Yeah, that's always a good one. A lot of times with my pediatric patients that I experience, I'll come up, I'll take my skis off. Mountain safety already has their skis crisscrossed, so I'll put my skis next to it. Just follow your protocols. And I think what helps me, I've been a parent. I've had little kids. My kids now are adults, 30, 31, 32. So I've done this a couple times, but I think sitting down at the child's level, either kneeling, in front of them, put your hands on your lap. Hi, my name's Mark. I'm from Copper Mountain Ski Patrol. How can I help you? And again, yes, that's my introduction. Yes, that's my consent, even though they're minor. And just, I think getting on their frequency, again, age appropriate, and just looking in their eyes. One thing that I think we all can do is do our best to exhibit empathy, and just listen to the child. you have to be patient and you have to have times of silence and pause. And sometimes this might be a little kid that just, they're cold. How are you doing? Hey, where's your mom and dad? Are you cold? Yeah. Do you want some hot cocoa? Yeah. And I'll still do my head to toe. Don't miss anything because there can be something occult that you can miss. But I just think getting on their radio frequency and try to remember when you were a child. It might be generational, but still, I think, you know, helping them out. I might be in the park where this kid took 100-foot line and he jumped, and he's a 14-year-old, summit, you know, racing team or whatever, and he just took a big land and, hey, dude, what's going on? And so, again, um, just trying to, again, not act cool, but just like, hey, what's going on? Did you do a McTwist, a 1080? What were you doing and stuff like that? And just trying to, trust in those few seconds. It's hard, especially when we teach our kids, stranger danger and this, and and the world we are at 2026. So I think approaching the child slowly. Do they have a parent or guardian with them? Are they a young adult without or with friends? And just trying to display empathy is going to be important.
Getting all kinds of great comments here. Um,
CSM also possible the need for parents, relatives of the patient. Yeah, yeah. Um, uh, was it last year? No, the year before. A year before, we had a cardiac arrest on Rosie's Run. 21-year-old just found in the middle of the mountain. The stats that I keep is 60% of all of our CPRs are trauma related, at least per ME results. And so, being like the third person on scene, first ALS, and we resuscitate him. We got Rosk. We got him to the base of our mountain, our emergency department, and flights took him to Denver. And the kid had a bleed. He had a spontaneous bleed, and he was with friends. No drugs or alcohol, but sometimes it's like so. The good news is right after sweeps, the people that were on scene, we met in one of our facility rooms, and we had a counselor and a social worker, what have you, facilitate the process. And we actually have a 3-3-3 program. Well, it's kind of like a 1-3-3. And we met now after sweeps, and we talked and did that. In 3 days, we got a call, follow up from a lead. Hey, how are you doing today? 3 weeks from then, hey, how you doing? And in 3 months, even if the resort's closed, we get communications, the 3-3-3, and in 3 months, hey, how you doing? And that just helps our resiliency and our wellness for everybody. And great question about relatives of the patient. I'm not sure we've ever done that, or parents, but I do know for a team we have this system. The other shameless plug that I have is we actually have a counselor or social worker that skis with us once a week, Becca, and she randomly skis with us, and she actually checks in with us. She just skis and rips, and that's just a benefit of the patrol that we've had as a, hey, just another support person. It's one thing your boss coming up with you, hey Mark, hey Goldstein, how you doing? Fine, but it's another thing that Becca, a trained, she presents things or asks things in a different manner, and I think that helps the resiliency element. For all of us. Yes, empathy. Who's empathy is the key. Yeah, was it Brene Breen? She's just another great speaker on empathy and how we can effectively communicate, with compassion, which I think is huge. Another element that we can always brush up on. Yeah, and if anybody's out here this year or next year, what have you, you're out west, you're in Summit County, give me a call, look me up. We can do some laps, and yeah, it'd be fun.
this was great, Mark. Thank you so much.
You are most welcome. I hope everybody has a great evening and get some dinner and rest.
just want to put up real quick in case you haven't given any feedback. Please complete the form. Also, if you're interested, next month we are doing a burns patrol workshop. So I'll just put that up real quick and then I'll get back to you, Mark.
Oh, that's great.
I have one quick story to share with about a little child. We were looking for a child who was separated from his parents, and I happened to find him. And the description was he was wearing a Goldstein bear helmet. So I find this child, and I went up to him and I said, "Hi, my name's